spoken to people as well, just because, obviously you have a lot of people who reach out to you online and everything, in this whole space. And there are a number of people who have basically said to their cardiologist, yeah, I don't really feel comfortable taking the statin. And the cardiologist says, if you don't take the statin, you don't get to see me anymore. Like, I won't treat your other conditions, your other cardiac conditions, if you don't take this drug, which I think is a bit on the level of extortion, really.
Well, have you, as you know, I co-authored a paper recently on the benefit of statins with David Diamond and Ben Bickman. And that's actually been incredibly well received. It's had something over 50,000 downloads. It's in the top 1% of papers ever published in terms of views. And it's, so check it out if you, it's just look up, anyway, Google David Diamond, Ben Bickman, Paul Mason, and statins, and you'll come up with that paper. It's open access, so free to download. But what we actually did, we analyzed the data of the statin trial. So first of all, let's make something clear. So we've got two types of indications for statin therapy. One's primary prevention, one's statin secondary prevention. Primary prevention, number one, it means you want to stop having the first heart attack. So there is no compelling evidence that statins are beneficial if you've never had a heart attack, full stop. So let's just throw that out to one side. It's not even worth going there. That's out, that's gone. Number two, secondary prevention. You've got cardiac disease already, or you've had an event, or so on and so forth. So we're looking at reducing harms. So this is where the story gets a bit murkier. So when we analyzed, well, there's other papers that had already done the analysis. We just, collated a few together and presented them all as one. And they actually looked at the benefit of statins for secondary prevention with reference to triglyceride and HDL levels. And what you actually found is that any measurable benefit of statins basically diminished to the point of insignificance if you had a good triglyceride and HDL level. And so people on low carbohydrate diets, we know that the trend for their triglycerides and HDL is towards one of improvement. The triglycerides will go down, the HDL will go up. So in essence, what our paper says, that if you have a typical lipid response on a low carbohydrate diet, which may mean that your LDL goes up because you're not having these fake plant cholesterols, but you should also have a lowering of your triglycerides and an elevation of your HDL. And if you've got that trifecta of findings, and you end up with a good triglyceride to HDL ratio, then there's no substantive evidence that even if you've had a heart attack before, secondary prevention, that you'll derive a mortality benefit from consuming statins. Now, we actually put this paper, so I was actually invited to contribute to this paper by David, and he basically had a lot of the science. And I said, well, look, what we really need to do, there's a lot of clinicians out there who want to stop their patients' statins, but they feel threatened. They don't feel that they can do that. And I know this for a fact because I get questions, I get emails, I get phone calls from these doctors all the time asking, what can I do? What should I do? So by publishing this paper, it's got over 270 odd references. It's very well researched. It's something that we're very proud of. And it very clearly presents the data. And I've actually given some cardiologists and lipidologists the chance to rebut any points that we've made in the paper, and basically they've chickened off. So Ethan Weiss was one who was making a lot of noise earlier, and unfortunately he felt it was unreasonable that he actually read the paper before we debate it. So he felt that that unreasonable request was a deal breaker. Yeah. So anyway, but that's the interesting thing. He's actually commented on a paper that he refuses to read. Yeah. If that's not the height, of audacity, I don't know what is.
Yeah, and just willful ignorance. I mean, how do you comment on something that you don't even know about? As John Stuart Mill said, if you only know your side of the argument, then you don't know much, because if you haven't heard it in its most persuasive form from the horse's mouth, not from someone else giving a straw man depiction of it, but from the mouth of Paul Mason himself, the author of the study, You know, you don't even know what the argument is. You don't even know what this paper is saying. So how can you comment on it if you don't even know the claims of the study? How can you comment on it?
To be honest, I was a bit disappointed. I was actually quite looking forward to it. But anyway, I'm sure, well, if there's any cardiologists or lipidologists out there who want to have a discussion, you know, and I'm not talking about some of those crazies who live in mum's basement. I'm talking about people who, you know medicine. Yeah, let's talk.
Yeah, absolutely. I'm just going to pause for 2 seconds. Okay, so just to sort of switch gears here, there's been a prevalence of increased depression, anxiety over the years, and a lot of people are finding that switching diets, even to keto, but especially carnivores, found that they've significantly improved their symptoms. What can you tell us about like depression, even the causes of depression?
Well, I think that inflammation plays a key role. So I'm sure you've all seen the research that when people get an acute viral illness, they also suffer short-term depression. And I actually think that this comes directly back to neurotransmitter synthesis. Now, I know that there was a recent systematic review that said, oh, the neurotransmitter hypothesis of mood disturbance is wrong. I had a look at that and I wasn't 100% convinced. I still think there is some evidence that neurotransmitter problems actually underlie a lot of mental illness. What I'm not convinced of is that the drug company has the solution. So the way I think about it is that we've got the major neurotransmitters are what we call the catecholinergic neurotransmitters, dopamine, serotonin, and noradrenaline. And their synthesis, you know, in states of depression and a few other things, and we have actually seen that there can be lower levels of those within the cerebrospinal fluid. The thing is, they're lower because there's a problem with the production. And the drug companies don't offer you a solution to producing more. What they do is they say, we've got a drug that slows the removal of those neurotransmitters from the brain. It just slows it down. So if you've got a little bit of this in your brain, it'll just mean that it hangs around for a little bit longer. And if you're thinking about it, if you've got a major deficit of neurotransmitters and you're just sort of slowing down the breakdown of one of them, how much impact is that going to have? And most people would say, yeah, not much. And that's probably true, because when we look at the data on the absolute efficacy of antidepressant medication, it's quite underwhelming. Like, it's marginal at best. I think you'd say that if antidepressants do have a benefit, it's a marginal benefit. And the reason for that is likely to be logical, because if the underlying root cause of the problem is deficient production of neurotransmitters, then what's, you know, just inhibiting the reuptake inhibitors, you know, which is going to make it last a bit longer, it's not going to fix the problem. So you might ask, well, you know, you're out on a limb here because everybody else says that either neurotransmitters don't matter, or, you know, where's your proof for this? So one of the first papers I came across that actually gave me a definitive basis for this theory was done in the 1980s, and it was on people with celiac disease. And they actually did lumbar punctures. They sampled the cerebrospinal fluid, the fluid that circulates around the brain, and they measured neurotransmitter levels within that. And they actually found that for people with celiac disease, when they consumed gluten, the level of serotonin in their brain fluid actually fell. And when they eliminated gluten from their diet, it increased. So we actually do have definitive evidence that dietary change impacts on the level of neurotransmitters within brain fluid. So I thought, well, that's a pretty good place to start. And then, well, is there any other mechanisms? Can we get any other biological understanding underlying these? So the thing about the catecholinergic neurotransmitters is that, you know, that they come from an amino acid, so tryptophan, and they have quite a complex biochemical pathway before they end up into their neurotransmitters at the end. And there's a number of cofactors that are necessary. So, for example, you need iron. And in a state of iron deficiency, that is therefore predictably, biochemistry says, if you don't have enough iron, then your catecholinergic neurotransmitter synthesis is going to be impaired. So does this potentially relate back to the guy with man flu who wakes up like an angry bear in the morning? Absolutely it does. So there's a condition, we call it nutritional immunity. And it was first coined in about 1975, but nobody's ever heard of it, but it's an exceptionally important concept, and it goes back to the heart of this. So it comes down to the fact that most any pathogen that can infect us needs iron. And our body is a buffet of iron. We've got iron circulating around in our blood. Wonderful, la-di-da. So any pathogen that invades our circulation has just got iron on tap. So it is a protective mechanism that we have, our immune systems have, that whenever we get an infection, that we reduce our circulating levels of iron, and we'd reduce it rapidly. So we've got what we can measure iron, free iron in circulating around in our blood. And we've done studies where we inject people with inflammatory chemicals, lipopolysaccharides, and we can get a reduction in circulating iron in the order of 50% within 2 hours following that. So this is a robust response that we have to inflammatory marker. So if we just take iron out of our circulation, though, sure, we starve bacteria. Yep, that's fair. So where does it go? So we've got a storage form of iron called ferritin. We store it in ferritin molecules. So what actually happens is that when you get inflamed, the amount of iron circulated around in your blood will reduce, and your amount of stored iron will go up. Now, the average doctor will do a blood test and say, oh, your ferritin levels are super high. You've got heaps of iron. You don't have an iron deficiency. But that's only half the story. So you don't have an absolute iron deficiency. You've got enough iron there. But the question is, can your body access it? So with an inflammatory signal, it basically means that you're channeling all the iron into storage, but you're not letting any come out. It's what we call a functional deficiency. So in the state of inflammation, when you say you get this virus, you get the man flu, you end up with a functional iron deficiency, and that's going to impair your ability to synthesize neurotransmitters. So I think this elegantly explains the concept that we see of why, you know, you get depressed when you get a viral illness or indeed any other short-term illness. And this is just a preserved response of our immune system, because it actually, by restricting the access of pathogens to iron, it makes it easier for our immune system to eradicate those pathogens. Unfortunately, all the biochemical processes which require iron are then going to be deficient. And that includes neurotransmitter synthesis. It also includes energy production through the mitochondria. We know that a lot of the functions within the electron transport chain within the mitochondria are dependent on iron. So you'll have less mitochondrial efficiency, less. So we know, for example, at work in sports medicine, that we don't want to put an athlete out on the park who's got a systemic illness, because they're just not going to perform. It's, you know, it's for the athlete's benefit and also to the team's detriment if you've got that athlete out there, because you're better off getting a reserve in who's healthy, who's going to be fresh and going to be able to perform at their capacity. And I'm sure, you know, as an ex-professional rugby player, you've found that in the past, when you've had a viral illness, you just haven't, you know, your repeat efforts, the maximum efforts, the anaerobic, you know, ability that you've had on the field is going to be necessarily harmed and deficient.
Yeah, it does. I was, when I was eating sort of a normal diet, I was sick all the time. I would get like a cold, like every single month. I would get pneumonia 2 or 3 times a year. So I had like,
and when you got the cold, your performance would suffer.
It would, but at the same time, I was sort of used to it because I was always sick, and so like, you know, my performance was just always like me playing sick was sort of was sort of the norm, and so it was just like if I was well, then it was like, oh, then it was just like outrageous what I was able to do. But yeah, no, it absolutely makes a huge difference.
But then let's talk about the difference between infectious inflammation and autoimmune inflammation. So everybody throws this word around, inflammation, like they know what it means. But in actual fact, very few people actually get a sense of what it is. It's basically a response of the body that will help it clear an infection. Because when we say autoimmune inflammation, that means the body is attacking itself, but that is an abnormal response. And the body is responding with the same chemicals, the same cytokines, the same signaling molecules that it would use if you actually had an infection. So the body is it basically assumes almost that you've got an infection. It's attacking itself. It's a case of molecular mimicry, and we can talk exactly about what autoimmune diseases are later. But let's just say when you've got a chronic inflammation, so rather than having a cold that you feel crap for a week and you feel a bit depressed and then you get over it and then your mood comes back, when you have autoimmune inflammation, that hangs around for months or years at a time. And that can then lead to long-term depression of your mood. And this is why we see these people will report profound improvements when they go on carnivore style diets with respect to their mood. And that's because once you eliminate the underlying inflammation, and they're probably treating background autoimmune diseases that they often may not know that they had, their body then is able to synthesize these neurotransmitters. It might have been that they were deficient in B12 or zinc, which are two other nutrients required for catecholaminergic neurotransmitter synthesis. It might be that they're freeing up their iron stores, that the iron is released from the ferritin. It might be that they've actually just got enough iron into the body. They might have had an absolute, whatever it is, but there's multiple pathways by which your mood can improve on a carnivore style diet. But one thing that really struck me, and I'm sure you've heard it before, is that people say that their relationship with food when they transition from a low carb or a ketogenic diet to a carnivore style diet improves immensely. Because a lot of people, so the paradigm is calories in, calories out, you just got to eat less and exercise more. And the fact is a lot of people try that and they end up with borderline eating disorders, because basically disordered eating behavior is the only way that you can maintain a slim physique on a standard high carbohydrate diet. You have to restrict, you have to purge, you have to over-exercise, you have to go without, you can't eat until you're full. It leads to a terrible relationship with food, one that's predicated on guilt and shame. So, and then people go to a carnivore diet and they say that they just change this, they no longer have this absurd craving for food, or they no longer, have to white knuckle it and when they see a chocolate brownie or something like that. And I believe the reason largely comes down to the level of neurotransmitters within the brain. So dopamine is a neurotransmitter that's involved in the reward pathway. It reinforces behavior and it makes you feel good. And in actual fact, the survival of the human species is predicated on dopamine. So there's two behaviors that we need to engage in as a species, otherwise we're dead. We need to eat and we need to procreate. And both those behaviors release dopamine into the mesolimbic pathway in our brain, and they're reinforcing. We release dopamine, we eat something, we engage in relations and we get dopamine and we say, hey, that was nice, we might do it again. And that's the dopamine is the chemical driver by which the human species actually is allowed to survive. Now, what happens though? So you can think about it that you are hardwired to chase dopamine. That's a fact. What happens if you've got chronic inflammation and your level of dopamine synthesis is deficient? You're living in a grey cloud, but you're hardwired to chase dopamine. That means the desire to change to get a squirt of dopamine into your mesolimbic pathway is going to be almost impossible to resist. And in modern society, how do you do that? How do you squirt dopamine? Living in Australia, 2022, how do you squirt dopamine into your brain? You eat something sweet, you eat some food that you should not eat. So this is the premise of binge eating, the premise of food cravings. I believe largely it makes sense that it's an effective or relative dopamine deficiency. And I've had dozens of patients who tell me that once they got on top of their inflammation, they went on a proper elimination diet, they figured out what the problem was, that they didn't have urges to food. They didn't have to white knuckle it. They no longer had to, live in guilt and shame. The problem is that, that you have craving and then you give into that craving because that's a biological desire that you simply can't beat. And then they'd feel terrible afterwards. They felt that they'd done the wrong thing. That's an awful way to live. And there's so many people who seemingly get their lives back. They get a sense of control back once they deal with that.
And then, and that's certainly something that we also see in some of the data, like Georgia Ede published a paper a couple months ago, just looking at just keto, not even full carnivore, with psychiatric patients with intractable conditions, refractory to medical interventions, major depression, OCD, bipolar, and even schizoaffective disorder. And they found that these people who medications had failed all improved with these dietary changes, every single one.
Well, and there's other realms to that as well. I mean, the ketogenic diet. So we know that insulin resistance is a genuine problem in the brain. So what does insulin resistance mean? Well, it means that the brain can't take up sugar the way it used to. So we know that one of the substrates, one of the fuels for the brain is glucose. And unfortunately, given its label as now type 3 diabetes, for example, with dementia, we know that as you get older, the brain becomes less efficient at taking up glucose. So there's parts of the brain in particular that become starved of energy. They just don't function that well. But the good news is that ketones can serve as an adequate substrate for this. So ketones are absolutely fantastic. They can cross the blood-brain barrier. They can actually then be reconstituted because fatty acids can't cross the blood-brain barrier. So if you're trying to build neural tissue or build new connections, so on and so forth, you actually need to have ketones in there to do that, by the way. So you have ketones, they can actually provide the brain with energy when glucose cannot. And we've actually got lovely PET studies, positron emission technology studies, where we actually use labeled glucose and labeled ketones and actually see their level of uptake in the brain. And you basically see that in a demented patient, there's huge tracts of the brain that are just not active. It's basically waste tissue. And when you get them in ketosis, that the brain just comes alive again. And there's plenty of studies that show that even giving people ketone drinks, you'll get a very short-term increase in cognitive function. I don't recommend ketone supplements. I think nothing beats lifestyle. But I mean, there's absolute, no doubt. And I'm sure that providing some of those regions of the brain with more energy through ketones, no doubt that would also facilitate neurotransmitter synthesis. So it's a combined effect, but absolutely ketogenic diets, for all manner of diseases relating to the brain, not a bad thing at all.
Yeah, definitely.